I'm Dr. Sanjay Naran. I serve as the ASPS University Dean of Pediatric and Craniofacial Surgery. I'm thrilled to introduce today's episode of Plastic Surgery Hot Seat, in which we'll be talking about gender-affirming care in plastic surgery. This topic is very much in the forefront of plastic surgery today. We're fortunate to have Dr. Stacey Francis and Dr. Noopur Gangopadhya provide their experience and perspective on adult and adolescent gender-affirming care, respectively. Today's podcast will cover general practices in regards to gender-affirming care in plastic surgery, as well as facial feminization surgery and controversies in adolescent gender-affirming care. I'm happy to turn the microphone over to today's moderator, Dr. Joyce McIntyre.
Hello, everyone. Welcome. My name is Joyce McIntyre. I'm a pediatric and craniofacial plastic surgeon at the University of Massachusetts in Worcester, Massachusetts, and I'm delighted to come to you today with Dr. Francis and Dr. Gangopadhya to talk about controversies in gender-affirming surgery. These are colleagues I really respect and my friends as well, and I'm just thrilled to be with them today to have a conversation that we might have anyway, and we've just hit the record button. So welcome. I'm going to let Dr. Francis and Dr. Gangopadhya introduce themselves.
Thanks, Joyce. I'm Stacey Francis. I'm also a pediatric and craniofacial plastic surgeon in Los Angeles. I run the craniofacial program for Kaiser Permanente for Southern California. And as of the last 4 years, also our facial feminization program, which was started in addition to the transgender program that we already run through Kaiser that's been present for about a decade. So thank you, Joyce, for the invitation. And I'm also excited to be here with good friends and colleagues to talk about a very difficult sometimes, but exciting topics and conversations.
Thanks, Joyce, for the invitation. My name is Noopur Gangopadhya. I am also a craniofacial surgeon, but I also do pediatric microsurgery at the Lurie Children's Hospital of Chicago and Northwestern University, where I serve as the Associate Program Director. I've been doing gender-affirming care for about the last 4.5 years, and we have a quite robust adolescent medicine program. So the entirety of my gender-affirming practice is in adolescents. So I have a little bit of a different perspective than Dr. Francis and Dr. McIntyre. So I'm interested to see how this discussion goes.
So fun. So just for our audience, we're going to have 3 kind of general areas. We're going to start out talking about general gender-affirming care in plastic surgery, some of the general themes, general topics. We're going to then talk about specifically facial feminization surgery, and then we're going to tap into Noopur's expertise around adolescents and some of the controversies in gender-affirming surgery in adolescents as well. So to kick it off, Stacey, we had a really interesting conversation where you were talking about appearance versus gender dysphoria and exactly what we're treating. Could you tell us a little bit kind of how you've arrived at your thoughts about that?
Sure. Yeah. I mean, I think as, plastic surgeons, aesthetic surgeons, we are very trained to look at the appearance of what we find to be supranormal or normal or subnormal. And sometimes when we might try to use objective criteria to evaluate those things, and sometimes there are objective criteria. I mean, we know certain nasopharyngeal angles that are, more masculine versus feminine, for example. But I think what oftentimes is interesting is to our patients, we are really not trying to treat an objective physical difference. We are really trying to treat what they perceive to be the source of their gender dysphoria. And it's just an interesting way that I've come about, because now actually in my consults, I don't really say, before I kind of go through the exam and the physical exam, I really focus on, what do you think is causing your gender dysphoria? Because to one patient, that might be their breasts, to another, that might be their face, to another, it might be their genitals. And I think if we keep in the forefront that although we want to put everything in a little box and kind of make it this objective criteria, because that's usually the type A surgeons we are, it just doesn't always fit with this population. And I think you certainly, as the professional, I find the patients really want you to evaluate them also and say, what you think. But I find that when you start the conversation really more focused on treating gender dysphoria and not treating numbers or criteria, I find that just is it's a better start to the conversation, and I think a better end to the conversation.
That's great. And as to our audience, a bit of a disclaimer, we're approaching this as a conversation amongst 3 surgeons who are very supportive of gender affirming surgery as a concept, but definitely are plugged into some of the controversies as well as where we're lacking data. So anything that we're saying, overall supportive, but we're going to be talking about maybe some things we don't 100% haven't sorted out as a field yet as well. So a little bit of history for the audience. WPATH is the historically sort of advocate organization for the rainbow population in terms of gender affirming surgery. And one of the things that I've noticed actually and learned from working with the community is 10 years ago, WPATH really set some guidelines about who is a candidate for gender affirming surgery and what kind of surgery. And that was meant to protect historically potentially a vulnerable population from predatory surgery. But now, and so there's specific guidelines that WPATH has set out, like, to have gender affirming surgery, you should meet X, Y, and Z criteria. And while that's useful, really in the rainbow community, what's a bit more popular and maybe more embraced now, this is again just my experience, that an informed consent model, so that to be a candidate, a good candidate for gender affirming surgery, you don't necessarily have to have had checked all the boxes, i.e. been on hormones for a certain period of time or presented in terms of gender identity in a very binary way. That may be a bit outdated, but certainly the surgeon and the patient you want to be able to present an informed consent model. This is the benefits, this is what we're treating, and these are the surgical risks. Noopur, could you tell us a little bit about kind of criteria you might be using for your adolescent groups and gray areas there or troubles you've run into?
Absolutely. I certainly think for adolescents, there is a big difference between consent, which really is this legal capacity to provide decision-making, versus assent. And we will see patients in our adolescent medicine clinic as early as 11 or 12, and we treat up to the age of 25. From a surgical standpoint, my population tends to run between the ages of 15 to 25. And I really feel that even a 15 or 16-year-old has quite a good understanding of the concepts of consent and is able to provide a lot of the decision-making capacity. So I agree, it can't just be a hard line that once you're 18 and you've checked all these boxes will allow you to have whatever surgery you want to have. And depending on the patient and the family and their social dynamics, sometimes we're able to get to the same shared decision-making in one visit. Sometimes it can take 3 or 4 before we get to the point that we're all on the same page. I think some of the additional nuances in the adolescent population is really making sure that there is a safe place for them to recover and that they're able to recover in a supportive environment. And I've actually found that my younger teenagers who are still living at home with supportive parents can sometimes do better than some of our college-age students that may not have an area of safety to go home to or a supportive environment in which to recover from surgery. And so I think we do follow the WPATH guidelines to an extent. And some of that is actually insurance related. So depending on the insurance companies, they may require that you have pictures of the patients before surgery. They may require a letter of readiness from a mental health provider and a letter of readiness from a medical provider, as well as a letter from the surgeon. Depending on the state you're in, the age of consent can sometimes be a sticking point for insurance coverage. I am fortunate in that I live in a fairly liberal state, and I have been able to make a good case for a lot of my patients that don't necessarily meet the age of consent of 18. And I think, again, you really have to advocate for your patients. And I think the patients and their parents end up being pretty big advocates and educators as well. So I think those are some of the nuances I run into specifically with adolescent medicine population. And I've learned, similar to you, Joyce, that we should use these WPATH criteria really as guidelines, as a place to start, but it's not always a hard and fast rule for every single patient.
Stacey, for the Kaiser program, what kind of mental health clearance, what kind of sort of collaborative team care happens before you, say, offer a facial feminization surgery?
Yeah, so we have kind of care coordinator nurses who every transgender patient or gender binary or any spectrum of gender fluidity that presents to basically their pediatrician or their primary care doctor are then referred to our transgender medical program. And we have kind of a director of the medical program, which predominantly, of course, endocrinology, but big part of that is the mental health. And so we do 4 top surgery and bottom surgery. We kind of have our criteria, but it is based, kind of like Noopur said, by the WPATH. So 2 mental health letters for bottom surgery and 1 for top, I believe. Don't hold me to that because I don't do top anymore. And for facial femme, there are no WPATH guidelines for facial femme. So we have kind of created our own guidelines, based on that we feel it should be similar as, as to the top surgery. And so we require a mental health letter. But I'm going to be honest, I've never had a mental health letter that says they do not think that this would help them. And so I think it's helpful, but I have definitely met patients who have a mental health clearance letter who I don't think are ready for transgender surgery. And that's a difficult discussion. And again, as I think it just, like any patient relationship, it just requires trust and a really clear kind of understanding that you are trying to do the best thing for them. And that doesn't happen overnight, but sometimes it just requires, they just want it, they want this, and they think like you're just trying to block it sometimes, which is you really have to establish that you're trying to do the best thing for them. It's kind of off the subject when Noopur was talking about her patients who do better with parents at home. I mostly take care of children, and when, never in my history in physical is like, normally do I ask, do you have anybody to take care of you after surgery? Or like, do you have a place to live? And I think I have learned from this population that those are 2 questions that I now incorporate into my history and physical, because I have operated on, it's embarrassing to admit, but I'll admit it here. I've operated on somebody who's homeless and I had no idea. And I did surgery and, she literally did not have a place to go.
Or someone to pick her up. Right.
And anyone to pick her up. And so, then we were she was, basically in the hospital as a hotel. And which is fine. That was the right thing for the patient. But it's just, there are social factors that don't normally cross your mind. Like, again, particularly for a pediatric, predominantly practice. So I agree with Noopur, some of those questions I think are really important. And so to get back to what you originally asked, Joyce, yes, we have guidelines, but it's just like you're all saying, they're not the end all be all. And sometimes they're, pretty accurate. It's a good start, but I think it's a launching pad for, really trying to make the right decision together with the patients. And oftentimes that goes very well, but as you all know, sometimes you're just not on the same page and it's difficult conversations.
To that end, for our listeners who maybe have been contemplating doing this work or haven't started doing this work or thinking they'd like to offer, gender affirming surgery, that's been impressive to me how, as plastic surgeons, a lot of our strength really lends itself to this work, and that, we're evaluating patients this is elective surgery in the sense of it's not emergency. It has profound impacts on our patients' health, both physical and mental, but assessing is this the right time and is this the right surgery for you? And our antennae as plastic surgeons are very good at that in sort of typically, if you really pause, understanding are you in the best place physically, emotionally, and I even say to patients spiritually, whatever makes you the best you, is that all up leveled right now? Is this the right time for the surgery so that you can really thrive? And that's a core vein of what we do as plastic surgeons. Mm-hmm. So to move on to facial feminization, one of the topics, some of the stuff we wanted to cover, like what is reconstructive, what is cosmetic. Stacey, I know you're doing a lot of VSP. I personally have really embraced the VSP in my practice to kind of minimize risk and maximize surgical gain. I think to good effect. Patients have been very happy. So I'd love to hear from you what you may or may not be doing around that and how you're sort of tailoring all that can be done in the face to create a more feminine appearance.
Sure. Yeah. And I actually don't do a lot of VSP, but I'll tell you kind of how I approach things. And, when I train, the residents coming through, I'm an associate professor at USC. I should have said that in the beginning, but we work a lot with our USC residents, and it's always great for them to come in to one of my consults because I'm almost like clockwork. I do them the same way to kind of make sure I don't miss anything. And although I don't do VSP, what I find extremely helpful is before we meet the patients through our care coordination process, they all have a CT of the face. And I think it's very helpful for not only surgical planning, but I use it just to educate the patients. So the first thing I do is I take pictures of them, and in our system that gets uploaded to the chart. And so I have basically on the screen in the exam room, the pictures of them, and I go through all of the different frontal, lateral, worm's eye, and then their CT scan. And I really just go top down. I go I start with the top and just systematically, just like you would a facial fracture, I go front, hairline, frontal bones, orbital, nose, mid-face, lips, and then the jaw, chin, angle, going through all the areas. And I think the patients really enjoy seeing that. It's kind of like maybe like poor man's VSP in a way, because I really am making kind of working with the patient and explaining, do you see that prominence of your bone there, your forehead, and that's air, that's a sinus. And that's why in your case, we have to actually remove that bone if we want to make a big impact. I measure it, with them in the room. So I do a lot with the patient. And again, it's kind of, you're just like anything in plastic surgery. We are guiding it, but the patients are so much more invested if they feel like you're involving them in the process and you're not just dictating to them kind of what you think needs to be done. So I go top down. And then, like I said, I use the CT scan. I do measure. I probably should measure some more. I think when we first started the program here about 4 years ago for the facial femme part, essentially Kaiser was like, so why don't you just tell us what should be covered? And I was like, that's, if somebody has figured that out, let me know. But, again, it comes back to gender dysphoria. It doesn't really even matter what the forehead height is and what the nasofrontal angle is. But in the realm of the world that we live in with insurance, and, even though our system is different, we're still insurance. It's just, we are our own insurance. So I looked at like Farkas's, anthropometrics. I looked back at some of the original, Astor Health studies, and I don't think we have a perfect answer of that. I'd be very curious as to what you all say. I think there has been a little part to, at least in the beginning of practice, that I do focus more on the bones, and I focus on what we can objectively change, and what we know objectively is very different between a male and female skull. And so I think in general within Kaiser, we do a little more focus on bony work as for sure reconstructive. And that's obviously the frontal bone, nose, jaw. But for instance, like malar augmentation and lip augmentation, we currently do not cover that based on that being more of a soft tissue augmentation. And based on, is there any really good data to show that female zygomas are wider? Not really. We know the face that, is wider in the midface and more narrow at the lower third is more feminine, but that may not mean that the malar needs addressed. You may need to just address the jaw. So that's a long answer for I kind of use bony landmarks and bony anatomy as the guiding for what is kind of covered and not covered, but there's certainly still gray area within that. And lip length, we do measure lip length. Again, we just basically looked at Farkas's anthropometrics and, 2 standard deviations above that. Again, we're kind of making this up because there's not a lot of programs that are doing a ton of it with our type of insurance model. So it's the challenge, but it's also kind of fun because I think we're really helping our patients. And, again, as long as you approach it the right way, it's very rarely contentious,
No, and to that end, it makes me think of what we were saying earlier about really listening to the patient, what bothers them. And that is a really important piece. And then in building rapport with them as a craniofacial surgeon, helping them, guiding them, or suggesting to them what may contribute to being recognized or gendered in one way or the other. And that sometimes is new information to them. Yeah. And one of the privileges of taking care of the rainbow population is they've taught me so much. And one thing about language, I remember saying several years ago with a patient, bang for your buck. And this will give you the most bang for your buck. And what I meant was this will be incredibly feminizing. Patient had a really prominent frontal orbital brow. And this is how we're going to do it. And you're really worried about being misgendered. This is anthropometrically going to give you a big improvement. And she was like, I have great insurance. They're going to pay for all of this, blah, blah, blah. And I was like, oh my gosh, you just taught me so much about communicating with you. What I meant was maximal gain with minimal surgical risk. And what she took it is finances. And we actually had a good laugh about that. And I've changed very much how I speak with patients about that. And I'm very clear now, maximum gain with minimal surgical risk. Mm-hmm. Noopur, how are you thinking about the face in kids or in the under 25 crowd?
Absolutely. So, we again have that mixed population, and similar to my cleft and craniofacial population, I don't really consider a lot of these procedures until they've reached dentoskeletal maturity. So similar to how I think about the timing for cleft rhinoplasty or orthognathic surgery for my adolescents, I'm using some of those same guidelines for facial feminization. And I will admit, I have certainly not done the same volume as Stacey has and as some of my adult colleagues. But since we are able to treat up to age 25, a lot of the patients that I've done their top surgeries on really want to continue working with me at the Children's Hospital. And so I agree with Stacey that a craniofacial CT scan can be incredibly helpful. And I think my kind of two biggest areas tend to be rhinoplasty and jaw surgery. And I'm doing some exploratory forays into the frontal sinus and the frontal bone. So I think it's really helpful to take those measurements. And similar to how we use Dr. Farkas's textbook for cleft lip measurements and for head shape measurements, I think there is some role for that in facial feminization and facial masculization surgeries. So I think that is also, again, going to be a big area for research and objective data as we look at the next 10 to 20 years in gender affirming care.
For sure.
Before we transition to adolescents in general, any thoughts on social media? Have you guys, I know the rainbow community can be particularly empowering and very supportive, leveraging social media for patients that maybe feel marginalized. I have not delved into my profile, like what patients are saying about me on social media or anything, but has anyone thoughts about that, or even how that space may be influencing the aesthetics that a patient may be seeking?
Absolutely. It's a very small world. I think a lot of the transgender community, for very good reasons, need a strong community and find a home in some of the communities that are online. And yes, I have many patients who are, like, oh, well, you did so-and-so's and so-and-so told me I had to come to you or whatever. So it's a very small world in terms of that. And I think just like the rest of plastic surgery right now, people spend so much time looking at themselves or taking pictures that it's just a part of our world now. And I think it does make it all a lot more difficult to kind of, I guess, not focus on something about your face that maybe is masculinizing or you feel dysphoric about. And so I think it plays a big role. An interesting thing that actually, I don't always do this in my H&P, but in my exam, but I have some patients who will on Snapchat, I don't know Snapchat, but apparently you can kind of like make things like change your face. And so I will have had many patients come in and are basically like, I would like the angle of my jaw to look like this. And, it's saying it out loud, it sounds pretty obnoxious, to be honest, but there have been times where it's actually helpful because they're trying to express something. And I am like, well, do you mean here, like here, we're looking at the CT, I'm telling them what I think. So I think social media, that is just like a funny little tidbit about how sometimes social media, I guess, can be helpful. But I think overall it's very difficult because just everybody's looking at their face, taking selfies, taking pictures. And, we live in a society where that is, just constant. And I think it makes it a lot harder to sometimes achieve, exact perfection, but easier sometimes to communicate about their desires.
Noopur?
From a social media standpoint, we're a little more limited, especially since my population's all pediatric. So for the most part, I don't usually post patient results on social media. However, I have had a lot of patients reach out to me on social media. So what I do try to publicize on my personal social media is really education. So if I'm giving a talk about gender affirming care to our nursing team, to the adolescent medicine clinic, to a parent and patient kind of information night. That has been a way that some of the patients have reached out to me. And I do think the word of mouth is really helpful for this population. They are very well connected. They're very savvy. They are able to organize incredibly well. And that has really led to a lot of political action as well as advocacy. And so I think as a group, they're very empowered. And that has been really helpful as well for patient referrals, but also to give us feedback on what we can be doing better as an organization, as well as a clinic, to make patients have the best experience possible, as well as, kind of bring the parents along for the ride in my population. I agree with Stacey. I have had patients bring in Instagram filters or Snapchat filters that have shown me potentially, what features they want emphasized. And we also will talk quite a lot about the impact of looking at yourself head on versus the selfie and certain angles. And so I think some of the morphing features we have in a lot of the 3D, MD, and the Vectra, not to mention products too much, but kind of 3D photography apps has actually been really helpful for the patients, because a lot of them, especially my younger patients, don't quite realize that the selfie is not exactly how the world sees you. And that has been pretty empowering for them to really look at the 3-dimensional representation versus what they see on their phone in determining what's going to be realistic and what is not achievable.
So again, the patient's teaching me so much. I had my first patient present recently with a mental health support letter for top surgery from Plume. So just for our listeners who are like trying to keep their finger on the pulse, I dove into what Plume is, Plume, and it's a pretty cool online-based healthcare delivery service actually for the rainbow population in terms of trying to increase hormone support and access to hormone therapy, as well as providing access to the population for mental health support letters for gender affirming surgery. I don't know if it's including bottom surgery, but certainly top surgery. And the model is basically leveraging the access, that the internet can provide for basically a subscription-based fee, like $99 a month. You can get your letter of support as well as your ongoing hormone prescription. I don't know if that's good or bad, but just to put, it's run by a bunch of what I can tell board-certified family medicine doctors who are trying to take care of their population. And certainly I think the intentions are quite good. And we'll see what the data bears out because it's using the internet to potentially increase access to care. So just to put that on everyone's radar, Plume, Plume. So with that, let's talk about controversies in adolescent care. Noopur, tell us about what are your adolescent medicine docs doing in terms of what's in vogue about suppressing primary puberty or not? I know there's controversies in the endocrine world about that. What are you doing in terms of the brave new world of bottom surgery as a microsurgeon? You have spectacular expertise. Would love to hear about that.
Sure. So just to bring up a couple of things. So I think a lot has actually changed even in the 5 years that I have been here. And certainly, again, educating yourself with the patients, but also with your adolescent medicine or medical colleagues has been really helpful. And so when I first got here, I didn't seem to find as many patients on hormone blockers, but certainly over the last 5 years, that number has continued to go up. And I think part of it is that they are getting referred at earlier and earlier ages. So I think when I was going through training and fellowship, we barely talked about gender affirming care. And I certainly didn't see any of these surgeries or this patient population as a resident or as a fellow. And then it seems like when I started practice to now, we are seeing patients as young as 9 or 10 or 11. And so they have a lot more options open to them than when you are establishing care with, say, a 25 or 30-year-old patient. So I think we explore all of the options. We are fortunate in that we also have an oocyte preservation program here as well. So that has been really helpful for some of our patients that want to preserve their future childbearing, even after going on hormone blockers and hormone replacement or suppression, depending on their preferred gender or agender preferences. And I've also seen that our pediatric surgery colleagues have also gotten involved. So we're actually seeing a lot more uptick in the placement of supralimb implants. And I think a lot of my patients are shying away from kind of oral contraceptive methods and picking other alternatives. It's been a pretty steady uptick in the number of patients that are going on testosterone and testosterone at younger ages. And I think certainly for my female to male transgender population for top surgery, I have found that my rate of periareolar approaches for top surgery has actually increased just by the fact that they are suppressing breast development much earlier. And then they kind of immediately transition to testosterone around the time that you would go into puberty. So I think the rate of periareolar approaches and keyhole approaches for adolescent top surgery is much higher than you would see in a comparable adult population. I think the other thing that is somewhat controversial, of course, is bottom surgery and age. And so I personally don't do any bottom surgery, but I have some excellent partners on the adult side that recently started a gender affirming practice about 2.5 years ago at Northwestern. And so essentially what we do is we graduate those patients to the adult side where they have a full spectrum of OB-GYN, urology, and plastic surgeon microsurgery. Now, that said, I can imagine a particular point in the future where they would prefer to keep their care at Lurie. And then I, as a pediatric microsurgeon, would probably be involved in that. I think for me to get to that point, though, I would definitely need to do some additional training to be comfortable with the techniques and kind of the pitfalls and pearls to make sure that they have a good bottom surgery experience.
Thank you. And before we close, I think one of the population teaching me is that our binary sense of gender and how important that is, male and female, is potentially evolving. And I think it's probably a good thing that I say to my patients, like, the tent is broad, the tent is big, and it doesn't really matter to me what words are right for you, but what are we collaborating around your surgical goals here? So I certainly have a significant population of transgender men who are very interested in not seeking bottom surgery for a variety of reasons. And that's actually one of the kind of cool things of seeing the tent get bigger, is that there's all sorts of options for this patient to really step into their best self. And it may be surgery, it may be a single surgery, it may be, what people traditionally thought, top and bottom surgery, and each patient is really unique, and that is really awesome. I had one patient say to me, I'm not male, I'm not female, I'm N, and that was their name. And I was like, rock on, that's awesome, right? And, she was identified as female, that worked for her. But, her was a good pronoun for her. But like, it was just, the tent is big, and that's spectacular to see as a plastic surgeon. So. Dr. Francis, when we were talking off mic, you had a really good conclusion thought, I think, about research and impact our surgery has or doesn't have, and what we don't know about mental health and suicide. So you want to just give us a summary to send us off here?
Sure. Yeah, I think, again, it is a lot. Some of what we don't know is the effect of what we're doing. I think those of us who treat the transgender population, are really passionate about, we think we're really helping them and we're doing good, but what does that mean, right? And again, we're all scientists too. So in the end, is that affecting mental health conditions? Is that affecting suicide rates? In the adolescent population, almost 2% identifies transgender, and 30% have attempted suicide. That's a huge number. And so I think what we don't know is what the effect of what more institutions and more insurances are covering for this population. Is that going to have an effect on mental health rates, on victims of violence, which we all know happens to them? So I think I don't have the answers on that. I think some of the bigger programs have the potential to ask some of that and to have answers on that. And I'd love to kind of see some bigger organization that's going to track some of that information and what surgeries are most impactful. I guess I won't use bang for buck anymore based on Joyce's experience, but what is going to be the most impactful for the mental health conditions, which is a lot of what we're treating, and we want them to all just be members and productive members of society and happy. And so yeah, I think there's a lot we don't know, but I think we're moving in the right direction, and it's really great to see both of your institutions and some of our bigger academic centers supporting these types of programs. And I think hopefully in the end, we'll learn more and have some data to show for it.
I can't really add to that, Stacey. I think that's really an excellent way to wrap up. And yeah, I think there's just a lot more to come. It's a really exciting time to be a plastic surgeon. And, as the innovators of surgery and of medicine, I think it's no surprise that we are really at the forefront of this in terms of hitting the, limits of what we can do surgically, but also making sure that we're doing it with a measured approach and judging our outcomes. I think, as plastic surgeons, really hold ourselves to high standards, and we want to still be on that leading wave.
It has, I think you both would agree with me in this conclusion statement. It is such a privilege and a joy to take care of the rainbow population and share our plastic surgery expertise around what is possible for them to go out and really feel their best and interact in the world. So it's anything that I offer as a surgeon, I've gotten back 50 times as a gift, both in terms of education and that patient and surgeon interaction. So thank you both so much for sharing your expertise. So fun. Really appreciate it.
Thank you so much.
Thank you, Dr. McIntyre, Dr. Francis, and Dr. Gangopadhya for a great conversation on gender-affirming care in plastic surgery. A special thank you to you, our listeners. It's important that we bring light to this topic in plastic surgery, as it's certainly something that has become more and more relevant in our field. Thank you again for joining us on Plastic Surgery Hot Seat, and be sure to be on the lookout for the next episode.